So hello everyone, welcome to this module on pleural effusion, a very simple and straightforward topic. Whatever question that you are going to get for your exam on this topic is likely to be a simple one. All that you have got to do is study this topic in and out very well, just one time, and that is it, okay, because this is such a simple topic to learn. Now let's start with the very basics. Okay, what is this pleural effusion? Okay, so let's start with the basics. Pleural effusion means it is a condition where you have excess of fluid in your pleural space. Okay, so much of fluid in your pleural space. So the question naturally arises, normally is there a fluid in the pleural space? Yes, there is. So in the pleural space, in your pleural space, normally, that is in normal individuals, you would have around say 5 ml to 20 ml of fluid. Okay, this is just a rough range. The value varies. Some books say 5 to 25, 5 to 15. So there may be minor variations, but on an average 5 to 20 ml of fluid is there in your pleural space, and this pleural fluid, it is formed from the parietal pleura. Okay, so it is the parietal pleura capillaries. Okay, you have the parietal pleura capillaries that actually form the pleural fluid. Okay, the parietal capillaries. Okay, and the reabsorption of the fluid that is formed is by the lymphatics. Okay, so formation, it is the parietal pleura capillaries, and the lymphatics of the pleura is involved in the reabsorption of the pleural fluid. Okay, and the pleural fluid is formed from the parietal capillaries at a rate of around 0.01 ml per kg per hour. Okay, so that is the rate at which the pleural fluid is formed, but correspondingly there is a reabsorption by the lymphatics. So you see here, between the parietal pleura and the visceral pleura, you have the pleural space, which normally has about 5 to 20 ml of fluid. Okay, and this fluid is formed by the parietal pleura capillaries. Okay, so once the fluid is actually formed, it is reabsorbed by the lymphatics. Okay, you have the various lymphatics that is involved in reabsorption of this fluid. That is how the normal balance of pleural fluid is maintained in the pleural cavity. Now when you talk of effusion, pleural effusion, due to some reason there is excess of fluid in the pleural cavity. Now when you have excess of fluid in the pleural cavity, what all can be that fluid? Remember, this can either be a transudate. Okay, it can be a transudate. Number 2, it can be exudate. Okay. Number 3, you may have pus in the pleural cavity. Number 4, you can have blood in the pleural cavity. And number 5, you may even have chyle in the pleural cavity. So all these types may be there in the pleural cavity, and what we are going to do in this module is start off with learning the different types of pleural fluid accumulation. Okay, so let's see that. Okay, different types of pleural fluid accumulation means abnormal accumulation. That is what we are going to learn. All right, so just let us have a look at the initial comparison between a transudate and an exudate. Okay, the first two types, very important, very simple also. Let's try to see what is a transudative effusion, and let's try to compare it with a exudative effusion. Transudative effusion means, so let's see what is this transudative effusion. So transudative effusion is nothing but it is just that there is an increased amount of pleural fluid in the pleural cavity because of an imbalance between okay, imbalance between your hydrostatic pressure and oncotic pressure. Okay, there is a hydrostatic pressure, there is an oncotic pressure. So when there is an imbalance between the hydrostatic and oncotic pressure, that is when you get a transudative effusion. Now, what do I mean by this? See, you have normally a hydrostatic pressure and you have the oncotic pressure. And you know that this oncotic pressure is predominantly contributed by the plasma proteins. Okay, it is predominantly contributed by the plasma proteins. Now what happens is that in case of transudate, okay, the parietal capillaries, parietal pleura capillaries, either there is an increase in the hydrostatic pressure, okay, the hydrostatic pressure increases so that the balance is shifted in favor of your hydrostatic pressure. That is, when you take the difference of your hydrostatic pressure minus your oncotic pressure, that would be high. Okay, why? Because the hydrostatic pressure increases. Okay, so the difference will naturally increase. Okay, so then what happens is that when the hydrostatic pressure exceeds the oncotic pressure, there occurs a fluid filtration across this capillaries, okay, and this goes to where the pleural space. Why has it gone there? That is because the hydrostatic pressure is too much compared to your oncotic pressure, and because of this difference, there is an ultrafiltration of plasma. That is the key word. There is a ultrafiltration of plasma. There is an ultrafiltration of plasma. Now, the same occurs when, say, suppose your hydrostatic pressure is normal, but due to some reason, your oncotic pressure has gone down. In that scenario also, what will happen to the difference between hydrostatic and oncotic pressure? It will increase. And in such a scenario also there occurs ultrafiltration of plasma. So now do you get this point that a transudative effusion occurs because of an imbalance between what all factors? The hydrostatic pressure and oncotic pressure, ultimately translating to what? An ultrafiltration of plasma. Ultrafiltration of plasma. So remember, this is just an ultrafiltrate of plasma, and because you have a intact capillary endothelium, okay, there will not be any leakage of proteins, because per se it is the pressure dynamics that is being altered, and per se there is no damage or disease of the pleura. It is an imbalance between these two factors and thus resulting in an ultrafiltrate, which means it will be devoid of any proteins. Okay, and the fluid is what is called a transudate. This ultrafiltrate is what you call transudate. Very clear, very simple. Okay, now next type of effusion, that is what is we are going to, that is your exudative effusion. Okay, your exudative pleural effusion. Now what is this exudative pleural effusion? Exudative pleural effusion means here this occurs because there is often a disease of the pleura. Okay, so there is some disease that is involving the pleura. Okay, so in case of your exudative effusion, the disease either directly or indirectly, it is involving the pleura as well. That is, it is a localized problem. Okay, in case of your transudative effusion, it was not a local problem, it was a generalized problem, okay, with the dynamics of the pressure. But this one, there is some local problem there, there is some local disease there, as a result of which, okay, there occurs this leakage. How does that occur? Let's see that. You see this picture. Here what happens in an exudative effusion is, the most important point is you have got to see that there is some leaky membranes. Okay, you have all these capillary endothelial cells in the capillaries, so they become leaky. So there is a leakage that is happening, which means when there is a filtration that is happening into the pleural space, it is not just that it is an ultrafiltration. Some of the plasma proteins also would leak to the pleural space. So which means it is not just a plasma ultrafiltrate. This fluid is very much similar to the plasma fluid. Okay, the fluid that goes to the pleural space is very much similar to the plasma fluid. Okay, very clear. So that is what you call a exudative effusion. Okay, it occurs due to some disease that is locally affecting the pleura. Very clear. All right. Now it is very important for your exams to understand these two entities more. Okay, because if asked to put a single question from this module, I would maybe put a question based on this transudative and exudative. Okay, it is such a simple question, common question, but still, that is something that everyone should know. Now, what are the causes leading to a transudative effusion? Very simple, because I have already told you, transudative effusion means it is a generalized problem. Okay, so there is some problem in the pressure dynamics. So what are the likely causes? Remember, the most common cause of a transudative pleural effusion is a congestive cardiac failure. Okay, congestive cardiac failure is the most common cause of a transudative effusion. Now this can also occur because of other causes like your cirrhosis. Okay, because you know that in cirrhosis you have hypoalbuminemia. So what will happen to the oncotic pressure? It will decrease. And the same happens in nephrotic syndrome. Nephrotic syndrome, again very important. So the latter two is predominantly because your oncotic pressure is decreased. And in congestive heart failure, what happens is your hydrostatic pressure is increased. Increased hydrostatic pressure in CCF, decreased oncotic pressure in cirrhosis and nephrotic syndrome. Now these three are the most important causes of transudative pleural effusion. But there are certain other causes like your constrictive pericarditis, SVC obstruction. You can have even in myxedema, peritoneal dialysis, and also a condition by name urinothorax. So you might be wondering what urine is doing in the thoracic cavity. Well, this is a condition, the urinothorax is a condition where certain patients with obstructive uropathy, they may develop some retroperitoneal leakage of urine, and subsequently it may gain access to the pleural cavity, and thereby it might accumulate in the pleural cavity, that is known as a urinothorax. Now these are the causes of a transudative pleural effusion. Okay, so you see here in Harrison also they have given these causes which we have just seen: the congestive heart failure, cirrhosis, nephrotic syndrome, peritoneal dialysis, SVC obstruction, myxedema and urinothorax. Okay, so very important, these can be asked. Okay, very important. So these are the etiologies of what? Transudative effusions. Okay, but remember in your exam you have got to learn regarding exudative effusions as well. Well, the list of these transudative effusions were slightly smaller, but the exudative effusion is a larger list. Okay, so let's try to see what are the causes of exudative effusion. We will see the most important ones. Okay, most important ones. So exudative effusion, the most common exudative effusion that you have got to learn is an effusion associated with a pneumonia, which is your synpneumonic or parapneumonic effusion. There is a slight difference between these two terms, sometimes used interchangeably also. When the effusion occurs along with the pneumonia, it is called a synpneumonic effusion. but the later accumulation within a few days is what is called a paranpneumonic effusion. But in certain books, these terminologies, the synpneumonic and paranpneumonic, are used synonymously also. Okay, so synpneumonic and paranpneumonic effusion is the most common etiology. Okay, the most common cause of a exudative effusion. Then you also can have malignancies causing exudative effusion. Malignancies causing exudative effusion. And you can have tuberculosis. Tuberculosis causing exudative effusion. Okay. And exudative effusion can occur in the context of connective tissue diseases as well. Connective tissue diseases. So you may have in the context of a rheumatoid arthritis, Sjogren's syndrome, SLE. Okay, so you can have associated with connective tissue diseases. Then you may have exudative effusion associated with an acute pancreatitis. Okay, and esophageal rupture. Now, just to bridge these two causes, the acute pancreatitis as well as esophageal rupture, they predominantly cause left-sided pleural effusions. Okay, just keep that in mind. They cause left-sided pleural effusions. Now, remember, it is predominantly acute pancreatitis involving the tail of the pancreas causing the left-sided effusions. Yes, you can also have exudative effusion associated with Meeks syndrome. I am sure that you would have learned with your OBG lessons also that Meeks syndrome means this is an effusion that occurs in association with a ovarian fibroma and thecoma. Okay, ovarian fibroma or a thecoma, that is in association with ovarian tumors, you can have this effusion. So these are the causes of exudative effusion. Okay, exudative effusion. Now, just to say a few points on each of them. First of all, your synpneumonic effusion or paranpneumonic effusion. So, meanwhile, there is another point that you have got to know. That is, we learned regarding the various transudative effusions, right? These transudative effusions, all these causes, they are most likely to cause bilateral effusions. Because see, this is occurring because of a generalized problem in the pressure dynamics. So, which is why the effusion caused will not be unilateral, they will cause bilateral effusions. And all these causes of your exudative effusions, they may cause either unilateral or bilateral. You cannot be 100% sure. Okay. So, this may be either unilateral or bilateral effusions. Unilateral or bilateral effusions. Very clear? Okay. Now, just a few words which you should know with respect to each of these exudative causes. Just a couple of MCQs here. See, about this synpneumonic or paranpneumonic effusion, one important point that you have got to know is a synpneumonic or paranpneumonic effusion is likely to be a mild to moderate effusion only. Okay, mild to moderate. It is very, very unlikely that a synpneumonic effusion, okay, that is an effusion that is associated with a pneumonia, okay, is massive. It is very less likely that it is going to produce a massive effusion. So, if you see a patient who is clinically being suspected of pneumonia and has a massive effusion, do not think that, okay, this is matching. There is some problem, okay, because a pneumonic effusion usually produces a mild to moderate effusion, okay, never a massive effusion. Whereas your malignancy and tuberculosis are very well known to produce massive effusions. So, does that mean all cases of malignancies are large effusions? Need not be, but if an individual has a massive effusion, it is more likely that he has a malignancy or tuberculosis as the probable etiology. Okay. Then you can have effusions associated with connective tissue diseases. Again, this may come as a clinical scenario for your exam. So remember that RA, SLE all can produce pleuritis, pleural inflammation. So see, there is a problem in the pleura there. Remember I told you in exudative effusion there is something happening to the pleura directly or indirectly. Okay, and thus it is a exudative effusion. And the other points I have just said about pancreatitis, esophageal rupture and Meeks syndrome. So these are the causes of exudative effusion. Now I'll just take your attention to a table in Harrison, which I would say that this is a big table, okay, which is just to show you the causes of the exudative pleural effusion, which we have discussed, but just wanted to show you it is such a big list, okay. That is why for your exams always learn your the transudative effusions well and the most important causes of your exudative effusions, okay, and the rest of the thing definitely it is likely to be a exudative effusion, okay, very important. Now another point that I want to add here is about drug-induced effusions. So certain drugs are known to produce pleural effusions, okay, and usually the drug-induced pleural effusions are likely to have eosinophils in their pleural fluid as well, okay. They have eosinophils in their pleural fluid, okay. Remember, eosinophils in pleural fluid is not very specific to your drug-induced pleural effusion. Even if you have certain infections, certain parasitic infections like a Paragonymous Westermann infection, that also can have eosinophils in the pleural fluid, okay. But it is very important that for your exams you know the causes of drug-induced pleural effusions, because this is given in Harrison also. Very important, you have nitrofurantoin, dantrolene, methisergide, bromocriptine. You have procarbazine, amiodarone and dasatinib. Maybe you can add procainamide also to this list, but these are the most important ones. It is likely that in your exam they may give a scenario of a patient probably taking some drug like a bromocriptine. Okay, they might try to make it a lengthy question. So they might try to add, okay, the patient was on some drug like a bromocriptine for, okay, maybe a pituitary adenoma, prolactinoma treatment, and then he was found to have some effusion. So then you have to suspect a drug-induced effusion. But remember, this is not a common one, bromocriptine producing effusion, but that is how the entrance exam goes. Even the relatively uncommon things, the examiners are fond of them. So they would try to make a question just to trick you, but you should know the causes of the drug-induced pleural effusion. Very clear? Alright. Now having understood the causes of the transudative and exudative pleural effusions, next is regarding a criteria which would help you differentiate better between a transudative and exudative effusion. Because when you evaluate a pleural effusion in your wards, the first step that you have to decide is that is this a exudative effusion or a transudative effusion. So let's try to see what is meant by this Light's criteria. Okay, this is called the Light's criteria, a very important criteria, okay, with respect to your pleural effusion that helps you to differentiate a exudate and a transudate. So this criteria goes like this. There are three parameters in this criteria. Number one is that there are three parameters and any of the one parameter is positive. Then you say that this is a exudative effusion. So first one is a pleural fluid protein to serum protein, okay, more than 0.5, okay, and a pleural fluid LDH to a serum LDH value more than 0.6, okay, or if the pleural fluid LDH is more than 2/3 of upper level in serum. Okay, that is more than 2/3 of the upper level in serum. So you have 3 parameters in this Light's criteria, and if any of these is positive, okay, you say that this is a exudative effusion, just any one. Okay, but to call it transudative effusion, none of these should be true. Okay, so there is some bias for a exudative effusion, correct? So which is why it is said that one lacunae in this Light's criteria is that if you apply this Light's criteria, there is a chance that 25% of the actual transudates may be misdiagnosed as exudate. Okay, may be misdiagnosed as exudate. So that is one problem with your Light's criteria. Okay, very clear. Pleural fluid protein to serum protein, pleural fluid LDH to serum LDH, pleural fluid LDH more than 2/3 of upper level in serum. So you see what are the parameters that are being taken, the protein level as well as the LDH. That is the one used for Light's criteria, and keep in mind that they are not using the sugar values. Okay, they are not using the sugar values to distinguish a exudate from transudate in the Light's criteria. Just keep that in mind. Very clear? Okay. Now, having understood the exudative and transudative effusions, so just let me show you a X-ray. This is a bilateral effusion. So tell me one thing, is this a exudative or transudative effusion? Well, it is difficult to comment. All you can understand it, this is a chest X-ray, and it is obvious that you have a blunting of the costophrenic ankles, okay, and there is fluid in the costophrenic ankles. You can see the buildup of fluid, and it is relatively a milder effusion, but it is a bilateral effusion. If it was a unilateral effusion, you could have said this is not transudative. But since this is a bilateral effusion, this could be a transudative effusion as well as a exudative effusion. So that you have got to keep in mind. See, the X-ray for detecting a effusion is often a good tool and which we rely often. Now there are a few MCQs that you should know with respect to this about the utility of the X-ray, that when you have a fluid in the pleural space, if you go for a chest X-ray, see, if you go for a X-ray PA view, okay, X-ray PA view, you almost need around 200 ml of fluid to be seen in a PA view chest X-ray, okay, to be detectable. Okay, and if you say about, if you compare this X-ray to a clinical examination, to detect a pleural effusion clinically, you would require 300 ml of fluid. You would require 300 ml of fluid. So yes, X-rays can pick effusions which are, which are not picked up by your clinical examination as well. But remember one thing, if you are asked what is the most sensitive investigation to pick up an effusion, it is going to be a CT thorax. Okay, CT thorax is going to be the most sensitive, okay, to detect, most sensitive to detect a effusion. So if you are asked ultrasound, can you detect by ultrasound? Yes, you can do a USG thorax and detect effusions, but CT again would be more sensitive. So if in your exam CT is not given in the options, you can go for ultrasound for picking up the minor effusions. Okay, very clear. So previously we used to do the lateral decubitus view X-ray. Okay, so I told you the X-ray PA view can detect 200 ml of fluid. But remember the lateral decubitus view, okay, lateral decubitus view can detect even up to 50 ml of fluid. Okay, so even up to 50 ml of fluid can be detected by the lateral decubitus view. Okay, so that just keep in mind this question also. Lateral decubitus view, clinical examination 300 ml, but most sensitive is, even less than this 50 ml you can detect by CT thorax as well as ultrasound. Most sensitive is CT thorax. Okay, very important. So the next, yes, here what are you seeing? So here you are seeing a left-sided pleural effusion, correct? You are seeing a left-sided effusion, and it is quite obvious that you might have already learned about your Ellie's S-shaped curve also. Okay, in the effusion you have the Ellie's S-shaped curve, okay, which you are appreciating here, which is because of the fluid in the pleural space. So some conclusion you can make from this is that this is not likely to be what? This is not likely to be a transudative effusion. Very less likely. Because if it was transudative, more likely it would have been a bilateral effusion. That you have got to keep in mind. So another case I'll show you of a patient with a massive effusion. Remember I told you in the causes of exudative effusions, you can have massive effusions associated with malignancies, tuberculosis. Often it, if it goes very high, it can actually, if it is above the second rib, that is when you say it is a very massive effusion. And when such massive effusion happens, this fluid, okay, when you lie on the opposite side, suppose if there is a left-sided effusion, as in this case, left-sided massive effusion, when the patient lies to the right side, the fluid would sometimes, shift towards the medial side, and there can be some compression of the mediastinal structures, and it can actually increase the breathlessness. So when you have a massive effusion on one side, lying to the opposite side would cause breathlessness, and that is what you call a trypopnea. Okay, trypopnea. So that is usually associated with massive effusions. So what is this trypopnea? In massive effusions, when you lie, to the opposite side of the effusion, because of the fluid shift and subsequent compression, you may experience breathlessness. That is called a trypopnea. Okay, so remember this also. Alright. So this is another massive effusion you can see here. So here you can see appreciate the tracheal shift also. A massive effusion, almost like the whole lung, you are not able to see such a massive effusion. It can cause a mediastinal shift also. Okay. So that is again a massive effusion. And this again I told you, ultrasound can be a very useful technique to detect small amount of fluid. Okay. So you can go for ultrasound. And CT thorax also a very useful test. Okay, you can see fluid here to detect effusions and to detect if there is some other underlying structural pathology. You can go for the CT thorax. Okay, all right. So you have learned regarding the differences between transudative and exudative effusions. So just one point to show you. Yeah, what do you show this? What do you see here? See here also you are seeing some effusion in the right side. But what is the peculiarity from the effusions that I have shown so far? Now something that is very obvious here is that there is a definite air fluid level. Okay, there is a definite air fluid level in this effusion. And when you have such a definite air fluid level, it is suggestive of what? Tell me, it is suggestive of hydropneumothorax. Okay, so this is a right-sided hydropneumothorax because the air is actually very light, so it would float higher and you would have a air fluid level which is seen in hydropneumothorax. Okay, very clear. All right. So we have seen in detail regarding the transudative effusions and exudative effusions. So remember I told you, in addition to the transudate and your exudate, you may also have pus in the pleural cavity. Okay, pus. So when you have pus in the pleural cavity, what do you call it? You call it empyema. You call it empyema. So empyema can result from various causes. Even an effusion which starts off as maybe a parapneumonic effusion, okay, there is some pneumonia and that has developed a parapneumonic effusion. What can happen is that there can be the development of a complicated parapneumonic effusion, because normally your parapneumonic effusion is relatively sterile fluid because it is not having an organism. So there can be a complicated parapneumonic effusion where you can have this fluid getting infected. So you can have a complicated parapneumonic effusion. So where the patient can develop empyema, the patient may develop some loculations in the pleural fluid. So all that can happen. So pus is actually called empyema. So again, it is slightly difficult to treat. You have got to be very careful regarding the diagnosis of empyema and appropriate treatment, because you would have to treat the infection part also. You can have blood in the pleural cavity, that is called hemothorax. And when do you call it a hemothorax? You call it a hemothorax when the ratio between the pleural fluid hematocrit to the plasma hematocrit or the blood hematocrit is more than 0.5. So that is when you call it a hemothorax. Okay, alright. So this hemothorax or blood in the pleural cavity, what are the scenarios in which that can occur? Very important. You have trauma, very important trauma. You can have malignancies, okay, malignancy, because malignant effusion can be hemorrhagic. Okay, so trauma, you can have malignancies like a lung malignancy. And remember, malignancy associated pleural effusion is more commonly seen with the adenocarcinoma lung than a squamous cell carcinoma, because the adenocarcinoma lung is more peripherally located, as you would have learned in pathology. It is having a more peripheral location and more chance of irritation of your pleura, and subsequent effusion is more in a adenocarcinoma than a squamous cell carcinoma. So trauma, you can have malignancies, lung malignancies, even mesothelioma also can produce a hemorrhagic effusion or your hemothorax, and sometimes tuberculosis. Rarely tuberculosis also may produce, but the first three are the ones most important. Okay, and the last one is chyle in the pleural cavity, which you call as chylothorax. Chylothorax, it is commonly that occurs when as a part of trauma. Okay, or you can say that whenever there is some thoracic surgery and there is some injury to your thoracic duct, you may get chylothorax. Okay, you may get chylothorax. Now, a very important point that you should keep in mind when you discuss chylothorax is chylothorax or chyliform effusion. Okay, chylothorax or chyliform effusion should always be differentiated from a pseudochylous effusion. Pseudochylous effusion. So, see, in chyliform effusion, what happens is that, or you can even call it a chylous effusion. So there it is the milky white color that you see in chyliform effusion or chylous effusion is due to the chylomicrons and the triglycerides. So that is what gives it the milky white color. A pseudochylous effusion would have a similar appearance, but again the level of chylomicrons and triglycerides are it's not high. And here what happens is that in pseudochylous effusion, often it is a result, it looks like a chyliform effusion, but often it is a sequelae of certain conditions like a rheumatoid arthritis. Okay, conditions like rheumatoid arthritis. And in this rheumatoid arthritis, what happens is that you will have cholesterol crystals. Okay, this is very important. Cholesterol crystals. Okay, you will have cholesterol crystals in the pleural fluid in your rheumatoid arthritis. Very important. So I will just show you a picture here of a patient who had a rheumatoid arthritis pseudocylus effusion. So yes, you can see here. You see the appearance here. Okay, it appears slightly yellowish here. So this pseudocylus effusion in the rheumatoid arthritis in this case, when this fluid was investigated, so this one is the right stain, and you can next see a wet mount preparation, and what you see here in the wet mount preparation is an appearance that is known as a shattered glass appearance, and the final one is the polarizing microscopy appearance. So all this is suggestive of a rheumatoid arthritis, is suggestive of a cholesterol crystals. Okay, that is what causes this shattered glass appearance, and this case was a case of a rheumatoid arthritis having pleural fluid cholesterol crystals. Now let me tell you one point, that every time a rheumatoid arthritis may not produce a milky white color. That is one thing you have got to understand. Because though it can produce a pseudocylus effusion, sometimes it might appear very much turbid, because as in this case also it is not a milky white color. So remember that rheumatoid arthritis is one of the causes of pseudocylus effusion. Doesn't mean that all cases of rheumatoid arthritis will be having a milky white color. Very clear? Okay. So having seen the various etiologies and what are the types of fluid accumulations that can occur in the pleural cavity, just let's have a look at the various fluids in the pleural cavity. You can see the different types of fluids. Okay, you can see there is a transudate, and then here you can see the hemothorax, and the next one is actually a case which was a exudate to begin with, and subsequently there occurred an empyema also. So this was an exudate. Okay, and so you can see some buildup of a pus-like appearance also in this fluid, because I told you your paranemonic effusions can get complicated, and you can have gross pus, because even in your exudate also you are having inflammatory cells, that is the neutrophils and all. But when there is gross pus, that is when you call it empyema. Okay, all right. And this one is the chylous effusion, a milky white color. Okay, chylous effusion. Okay. So all right. So far what have we learned? We understood the normal pleural fluid dynamics. We understood what all types of fluid accumulation can occur in the pleural space. We saw the causes of transudative effusion. We saw the causes of exudative effusion. And remember, always the order is pneumonia first, the most common cause. It's not tuberculosis, the most common cause of exudative. Do not get that question wrong. It is pneumonia. And then you can have malignancies and your tuberculosis producing effusion. And always remember, malignancies which are likely to produce effusion, always the most common is lung malignancy, adenocarcinoma of the lung, that is most common, very, very important, and all other peculiarities also I have said. Now, suppose you have a case of an effusion. Okay, how are you going to work up this case? Right, you have got to reach a diagnosis, right? So let's try to see how are you going to work up a case of pleural effusion. So regarding that, I will take your attention to chart in Harrison, that is a diagnostic algorithm to pleural effusion. Let me remind you, when you have a patient with pleural effusion, first of all, take a good history, okay, and then do an examination, because that will actually help you get the actual clinical background, because that again is important. Now remember, for your MCQs also, you must be knowing what are the examination findings in an effusion as well, because as you would expect, in case of a effusion, you tell me what are the findings that you would look for, the examination findings. So the specific examination findings, I mean, when you have a fluid in the pleural cavity, naturally your vocal fremitus, vocal resonance, both of them will be decreased. And what type of dullness are you getting? Stony dullness on percussion, okay, and on auscultation, decreased or absent breath sounds. Decreased or absent breath sounds because of the fluid in the pleural cavity. Okay, so these many points are simple points, but I just wanted to mention because it might come up as a part of your question. Simple ones. Now you see here, when you have a case of pleural effusion and when you want to evaluate it, the first step that you would go for is a diagnostic thoracocentesis. Okay, that is, you are going for a pleural fluid tap. Now when you go for a pleural fluid tap, which is called a thoracocentesis, there are a few points that you have got to know within this. If you want to go for a pleural fluid tap, first of all, which site will you choose for doing the tap and how will you do the tap? Regarding the site selection for doing a thoracocentesis, see, the ideal site is the 7th intercostal space in the mid-scapular line. Okay, mid-scapular line. See, if you ask me, can you do it in the mid-axillary line? You can do, but again, the more safer procedure is when you do it in the 7th intercostal space in the mid-scapular line. I'll just show you a demonstration. Okay, see, this is one patient where you see the pleural fluid is being tapped, and what you do is that you ask the patient to keep his both upper limbs in a crossed manner and then to slightly lean forwards, and then you do the fluid tap in the 7th intercostal space. But see, what is the mistake in this, what is the only probable mistake in this tapping is that ideally it is better to do under ultrasound guidance. Okay, because see, when you do this, the thoracocentesis, there is always a risk that you are likely to injure your lung. Okay, see, suppose if it is a massive effusion and you do it in the 7th intercostal space, it is very less likely that you are going to injure. Even if it is a mild to moderate also, you are less likely to injure. But still, if because of your faulty technique or defective angulation, there is always a small risk of injuring the lungs. So if you are in a facility where you have a ultrasound probe available, always go for a ultrasound guided thoracocentesis where you are directly visualizing the entry of the needle that you are inserting. So you can see when you're in the ultrasound machine itself, you keep the probe in the region of the 7th intercostal space. While you insert the needle, you are able to see the position of your needle. So it is more easy. Okay, so always what is preferred, a ultrasound guided thoracocentesis or the pleural fluid tap is preferred. So most often on seeing the appearance of the pleural fluid itself, it might give you some clues because an exudative effusion is likely to be clear. Whereas when it comes to a transudative effusion, you are likely to see a straw colored fluid, or when it becomes an empyema, maybe you will see a very much turbid fluid. You may see a hemothorax or you might see a chylothorax. So all that depends. And remember, when you do a tap, there is always a chance of injury to vessels and you might get slightly blood-stained fluid. So you might differentiate this from, you must differentiate this from a hemothorax. So I already told you how to say that something is a hemothorax. See, to call it a hemothorax, it should have a higher hematocrit as well. Okay, so you can see almost half of that of plasma should be there. That is why I told you about that ratio of the pleural fluid hematocrit to the plasma hematocrit more than 0.5. Okay, Alright, okay, the blood hematocrit more than 0.5. That is clear. So that is about your ultrasound guided thoracocentesis. Alright, so I told you the appearance of the pleural fluid gives you certain clues, but not just the appearance, you have got to go for the study of the pleural fluid as well. So it is quite obvious that the first thing that you would apply will be what? Your Lights criteria. So once you go for the tab, you apply for the Lights criteria, and if everything in this criteria is a no, it is going to be your transudative effusion. And remember, you have very less differential diagnosis when you have a transudative effusion in hand. And exudative effusion, remember, do not just stop with exudative effusion. Transudative, you can manage the corresponding condition, but exudative, you have got to work up more. Why has this patient developed a exudative effusion? So you have got to investigate more and more. So to find out the cause, you can go for pleural fluid glucose. See, I told you glucose is not a component of your Lights criteria, but there is one importance of glucose, that is this one. That is, when you have a significantly reduced glucose levels in the pleural fluid, that can occur because of certain causes like infection, malignancy, rheumatoid arthritis. Okay, these are the ones most important. But let me tell you one thing, if you have very less sugar values, sometimes even less than 35, 30, less than that, then you know the chance of rheumatoid arthritis is very high, because out of these three causes, it is rheumatoid arthritis that produces very low level of glucose in your pleural fluid. Okay, in fact lesser than that of your tuberculosis as well as malignancy as well. It will cause a decrease in the pleural fluid glucose value. Okay, so checking the pleural fluid glucose is important, and it is very obvious that you have to check for malignancy. So to check for malignancy, definitely you should go for what? You should go for a cytology, malignant cytology, because sometimes you might pick up some adenocarcinoma cells. It might be a breast malignancy, so you might be able to get some cells in the malignant cytology, and sometimes the cytology might not yield. So in such a case, you will have to go for a thoracoscopy and a biopsy of the pleura. Okay, so sometimes you might not get this yield in case of a malignancy. Okay, so do not always think that all malignant effusions, the malignant cytology will be positive. So if it is not positive and you are suspecting, go for a thoracoscopy and biopsy. And also in the pleural fluid, you can go for your infectious workup, like you can go for your, say, gram stain, culture. Very important, you can go for your CB-NAT, that is your gene expert. And remember CB-NAT, okay, the pleural fluid yield of the CB-NAT technique in the pleural fluid, the yield is not as great as in case of your other fluids, because I have discussed in the module where I have discussed the tuberculosis, I have said that the yield of CB-NAT with pleural fluid is only 43%. So a pleural fluid, a tuberculous effusion, see, that is, you must first of all understand that this is not a pulmonary TB, this is an extra pulmonary TB. Many of the students think that a tuberculous pleural effusion is a pulmonary TB. No, it is an extra pulmonary TB. And when you have a pleural fluid effusion as a part of tuberculosis, the CB-NAT yield is not that great. So sometimes you would have to go for a pleural biopsy. And in the biopsy specimen, you can go for CB-NAT to get the yield. Okay, that is also possible, which has a better yield than your fluid alone. So obtain the pleural fluid cytology, the differential count, stain, then you work up for tuberculosis. The common causes of the tuberculosis, common causes of exudative effusion, you have got to work it up. Okay. Now another point that you have got to know is that if still after the workup you are not yielding anything, okay, no diagnosis after that, then you should consider other causes, like say if the clinical setting is there, you can have a pulmonary embolism. A pulmonary embolism, an infarct can again produce a effusion, so that can be there. And again, if you are not able to reach any diagnosis, the final step is your thoracoscopy and the biopsy. And the biopsy you then do, and then probably in the histopathology you might be able to get some clues. One point regarding the effusions associated with the pulmonary embolism is that, see, we have seen the exudative and transudative effusions. The pulmonary embolism producing an effusion, okay, can either be exudate or transudate. Okay, it can very well be an exudate, it can very well be a transudate. Okay, and effusions associated with pulmonary embolism may also have eosinophils. Remember, drug induced effusion, we saw eosinophils in the pleural fluid. We saw that in the eosinophils in the pleural fluid were also seen in infections like Paragonimus westermanni. And here also you can see your eosinophils in the pleural fluid. So pleural fluid analysis is very important. And in your urinothorax, okay, urinothorax, there will be increased levels of creatinine in your pleural fluid. That is another point that you have got to know. Increased levels of creatinine in the pleural fluid. Okay. So just to sum up what we have learned in the evaluation, always the first step is to distinguish whether it is a exudate or transudate. Once you have seen it is an exudate, it is treat accordingly the cause, okay, which is relatively more easy. Exudative effusion is something that you are more worried about. You try to find out. The common ones are infections like a pneumonia, tuberculosis, malignancy. Sometimes connective tissue diseases can produce. Then we have already seen other conditions like a Meek syndrome. Okay, even asbestos exposure can produce. A big list of conditions are there. So work up for those conditions, and remember, pulmonary embolism, either exudative or transudative effusions. So we have seen regarding your effusion in detail, and another point that I want to add on is that when do you go for intercostal tube drainage, okay, or the ICD, intercostal drainage in case of a patient with pleural effusion. See, you go for an ICD insertion or a chest tube insertion. One indication is when the pleural fluid pH is less than 7.2, okay. Then, because normally it is around 7.6, the normal pH of pleural fluid. When it goes less than 7.2, then when you have a loculated effusion, you have to go for an ICD, loculated effusion. When you have an empyema, okay, gross pus in the pleural fluid, or maybe you are having a positive gram stain or a positive culture, in those scenarios also you would put a ICD, okay. So pleural fluid pH, loculated effusion, empyema, a definitive infectious indication like a positive gram stain or a positive culture. All these are indications for putting a chest tube. This is again very, very important. So, and the definitive management, well, the pleural fluid tap alone may help in some cases, but in many cases, sometimes, if it is a mild pleural effusion associated with a pneumonia, you might not even require a tap. Sometimes it may be a chronic liver disease producing a effusion, but still you went for the tap and you found that it is a transudative effusion. Okay, you correct the hypoalbuminemia, patient is going to be right. So, but certain causes you have got to treat accordingly, like a tuberculous effusion. The malignant effusion also, again, it is commonly seen in advanced malignancies. So there is always a chance of reaccumulation. Okay. So here, I would like to add 2 points here. One is that when you remove pleural fluid from a person, do not remove more than 1.5 liters. Do not remove more than 1.5 liters at a time. It is not that like ever you should remove the total amount is 1.5, not like that. But at a time, it is never remove more than 1.5 liters at a time. Because if you remove more than 1.5 liters, there is a chance of a re-expansion pulmonary edema. So because of this danger of re-expansion pulmonary edema, because of that, you will not remove more than 1.5 liters at a time. So that is one question I wanted to tell you. Second point is that, see, suppose if you have a malignant effusion, which is a rapidly reaccumulating effusion. So in such cases, what to do? Because the malignancy might have been the end stages. So this patient is probably suffering because he is going for repeated pleural fluid tapping. And since he is going for repeated pleural fluid tapping, it is always, some sort of a discomfort for him. So in that case, you can go for a sclerodesis. Okay, what you can go for, you can inject doxycycline in the pleural cavity, and this would create adhesions and would help to obliterate your the pleural cavity space, and this is known as your pleurodesis. Okay, this procedure is known as your pleurodesis, where you are trying to obliterate the cavity, which will actually prevent the further accumulation in the pleural cavity. That is very important. Okay, so we have seen that also the ICD insertion indication is very, very important, and ICD insertion is usually done in the mid-axillary line, 5th intercostal space. Okay, 5th intercostal space, that is where your ICD insertion is done. That also you have got to keep in mind. So we have gone in depth about pleural effusion, but remember, these are all very, very simple points. So just learn them once and for all. Straightforward questions you might get in the exam, but remember, this is like a full toss question. Do not make a careless mistake in a question related to pleural effusion. It will be a very simple one. So read the question carefully. What are they trying to ask you? And then answer accordingly. We have covered, most of the points of pleural effusion. Okay.